Okay, it looks like we are live at the new Cardiovascular Horizons Conference in Louisiana, New Orleans, Louisiana. Oh my goodness. Amazing conversations happening. Even one, if people can hear in the background, we have Dr. Eric Dipple that is up on the podium right now. And so you might hear a little bit of the rumbling behind us because it's being broadcast or simulcast into the exhibit hall where we are broadcasting live from the Global PADs Association, my association's booth, signing everyone up for our walking program, which we're going to nudge, nudge, nudge and get him into as well. I'm with Dr. J. Mathews. We actually have patients in our group that call him Dr. Miracle. It's fine if I say it here, probably tone it down when I'm introducing you to other doctors, right? But he's been, it means so much to so many people in our group and has done so much and gone above and beyond for so many people. Interventional cardiologist in Bradenton, Florida. Here at the conference, you've been on the podium yourself. What are some of the key points of your presentation that you're hoping that other doctors walk away with today?
Well, I get the pleasure of talking about a lot of different topics as course director. But tomorrow, actually, I'll be giving the keynote actually on our arterial thrombectomy. So, today they talk a little bit about calcium and managing calcium. My keynote will talk about clot and novel ways of dealing with clot, which is a big problem, both chronic clot, which is seen in a lot of PAD patients, but then also acute clot as well.
So can you give us a little bit of the tangible information from that presentation?
Sure. Well, I think one of the big things is recognitions of thrombus. So obviously, I teach a lot of docs about how to deal with folks who present with acute clotting episodes in their lower extremities, upper extremities, and whatnot. And we have a lot of great tools now, and I'll talk about that tomorrow too, tips and tricks for how to get through that and managing that without having to give really powerful blood thinners, or even more concerning, which is leaving it and then leading to amputation. Because that's actually something that's really important to understand is if you have an acute clotting episode, you have a 6-hour window before you have irreversible damage. And people who get sent to hospitals and just get put on some IV blood thinners, it's insufficient in order to salvage or save that leg. So unfortunately, that's been the way people have treated this for many, many years. And patients who do ultimately get salvage, where they get their vessels opened up, if they waited so long, they get left with permanent walking impairment, damage. Sometimes they lose their limbs anyway. So trying to teach people to get to this quickly, treat it urgently, and really restore flow so you can really minimize damage to those vessels.
So we did just have a patient recently, Valerie, who ended up with an acute clotting situation, and she rushed to the hospital. And of course, they started her on the heparin drip. And then I don't know the timeline. I guess it was within hours that she was on the table. I don't know exactly what they did, but the result was she ended up with a fasciotomy. And she was asking, why did I need this fasciotomy? And how could that have been mitigated and prevented?
Yeah. So what a fasciotomy is when you have restoration of blood flow, and if the muscle cells have been under stress for a long time, so that means they've been without blood flow for a long time. Again, really typically above 6 to 12 hours. And then all of a sudden you restore all that blood flow, the cells, they start to swell up. It's called reperfusion injury. And when those muscles swell, it becomes real big, beefy, and red, and you get what's called compartment syndrome. So literally the muscles swell up so much inside of these little compartments, like bags inside the leg. And if you don't release those compartments, you'll lose the leg. The muscle will die, and then you'll have to amputate the limb. So they have to do a fasciotomy, which is literally incisions made to release the muscles so that they can swell. And then over time, that swelling will come down, and then you can close those incisions back up again. But literally, you fillet the leg open in order to save the leg. This condition is largely preventable. If you show up to the hospital right away, they should be able to do thrombectomy, or essentially get rid of the blood clots right away and really reduce the risk of reperfusion syndrome. The problem is people who end up getting delayed reperfusion, delayed reopening of those blood vessels, they're the ones that are more likely to end up with compartment syndrome and need for fasciotomy than the people that get treated right away.
But how does the doctor know going in? We've had a situation where someone had the clot. It was probably a combination though of chronic and acute clot. But ended up with that. And the way the doctor described it was she poked the beehive and she wished she would have gone in with a little bit of a drip overnight to kind of soften things up.
Yeah, I disagree with that. And that's been like the mantra for a lot of people. The problem is it's the tools that you use. And I'll talk about that tomorrow as well for docs that are interested in dealing with these kind of patients. You want to do some type of procedure, whether it be aspiration or extraction, tools to really restore blood flow down that leg. And then if you have some leftover blood clots, small little areas of clot, that's when you can use the drips and whatnot too. When she talks about poking the hornet's nest or the beehive, what happens, you cross with a wire and then they try to go in and do something, maybe they balloon and then they send all of that clot downstream. And it's called trash foot. It's the worst thing. And then now all of a sudden your procedure takes so much longer. You lose a bunch of blood vessels. You risk causing gangrene. And that's why they said, well, I wish I'd softened things up with a blood thinner first. The reality is you want to, if you know that it's all soft and squishy and liquidy in there, you want to suck all that stuff out first and then reassess. And then if you need a little bit of adjunct to blood thinners, you could certainly do that at that point. But again, if you don't establish flow, that muscle is still dying. It's still in distress. And those people are going to be more likely to get reperfusion syndrome.
And so what are some of the questions that they can ask if they end up in the emergency room? How can they advocate for themselves to ensure that doctors act soonest?
I mean, it's really about communicating what they're feeling. You can say, if you're having numbness, you can't move your foot. These are what we're called advanced signs of limb ischemia. It's a lack of blood flow. So that is a very late finding. If your foot's going numb, if the leg is going cold, if you're not able to move the leg, so muscle issues and nerve issues are very late findings. That's very dangerous. Needs to be treated right away. Now, there's some people that present with a kind of a chronic, acute on chronic type thing, but they have what are called collaterals. So blood vessels that they have formed over time, they're still keeping blood flow going down to the lower limb. Those people are better off, and they tend to have less of a consequence after having a procedure done. But it's the people that really have no collaterals, they have no flow. They're the ones more likely to have nerve damage and muscle damage.
Can we talk about the aorta for a second? So we had a patient, Karen, over in California who presented the hospital. It was an HMO system with a blocked aorta. And it's pretty much 100% blocked, clear up above the kidneys. But it had to have been more acute clot because when she told me what was happening, she said that she forgot to take her anticoagulant medication for several days. It just was what it was. And she is a cancer survivor with radiation damage, et cetera. And so she just clots right back up. Frontline therapy for this, an axillary bifemoral bypass. And the doctor refused to consider when I asked him about a catheter delivery, a TPA, and then a thrombectomy. Or at least go in there, do endo, get the thrombectomy going. He refused, left her in the hospital for 5 days until she would come to grips with the fact that he was right and that he needed to do this. And she ended up with, bed sores, things like that. And then finally, we were able to have another conversation with him because he left for the weekend. And he said, well, if you want to have this endo, I'm not going to be responsible for it. I'm going to get you another doctor. Finally did it. And it was easy breezy, in and out. And she was out of the hospital within a couple of days. And when I asked the doctor why he was so adamant to do this axillary, and he said, well, we could just kick the can further down the road. He said, these TPAs, thrombectomies don't last very long. And so we got to do the axillary. And I said, but with the axillary, what's your contingency plan when that fails, if all fails? At least with the TPA, you still have maybe a thoracic bypass and then maybe an axillary.
Even an axillary bifem, that's still not the right operation, right? An axillary bifem is like, for somebody who's really not a candidate for anything else, maybe he was afraid of actually cutting into the belly or doing a retroperitoneal approach to actually do an aorta bifem. But in that kind of scenario, like axillary bifem is what you do when you feel like you can't do anything safely. But a lot of it's also education. A lot of people have never been formally trained to do endovascular work. There are some surgeons who are older or whatnot too have not yet had some of this experience. But what we're seeing now is that it's becoming increasingly more common in the surgical community to do an endo first approach for some of these things. Because I do believe that there are a lot of great surgeons out there embracing these technologies and trying these things and thinking outside of the box as well too. A lot of these, older type procedures, I mean, there's certainly a role for them, but we don't necessarily jump to those things right away. And in this particular case, especially with something acute like that, I can't talk about the particulars of this particular case because I haven't seen the films, but trying thrombectomy, sometimes doing some adjunctive lysis, especially if they weren't doing anything right away, there's certainly no reason you can't try it. And some people are afraid about doing it, especially if it's near the kidneys and risking sending blood clot into the kidneys. But that's why you can rescue with the thrombectomy solutions and suck out blood clot. If that does happen, reducing the risk of kidney failure and whatnot too. And it sounds like this was kind of a case where things were really close to the kidney arteries and they were afraid to kind of do anything.
Yeah, ultimately it was successful. They were also worried about the colon. And if you end up with clot in the colon,
well, a clot in the colon that's much higher up. So that's usually that should not be as much of an issue.
that's good. Okay, I want to turn to Douglas. I have to give you my earpiece. I apologize in this ear. Douglas, give it a second and then ask your question. Go ahead.
Welcome, and it's great to have you with us. Thank you.
Yeah, of course. Good to see you again.
We lost your audio.
I had an aorta bifemoral bypass.
Mm-hmm.
I had an aorta bifemoral bypass. It failed. Then I have an axillary bifemoral bypass, and it also has failed. Since then, I've had nothing but heart trouble. And I had a myectomy a year and a half ago.
Wow.
And the axial bifemoral is 100% blocked, but I have issues. I've had issues with finding somebody who's willing to take it out.
Right. Yeah, I mean, a lot of times once the grafts go down, they don't try to take them out, but some people will try to, in certain scenarios, try to open up the native aorta if it's possible. And that's a really complicated procedure and should be done at like a very experienced center where they can do a lot of these things. Now, for some people that aren't a candidate, you would go to a center that feels comfortable doing more complicated type procedures because if you've had a couple failed grafts and if they think that surgery is the right way to go, especially if you're a heart patient, then you need to be at a place where they do a lot of procedures, not some place like kind of dabbles in it, but an experienced center where they do a lot of both surgical work and endovascular work.
Have you heard where the axillary could actually affect the heart condition because it is blocked?
Not so much. Because usually what an axillary bifemoral bypass is literally they take a graft and hooked it onto the axillary artery, and then they use that to feed the blood vessels down the legs. And literally what you're doing is that the heart is pumping blood. Some of that blood, instead of getting shunted down the arm, a portion of it's being shunted down the legs. The big real risk with that too is not so much the heart, but rather the arm. Actually, sometimes you can have steal a blood flow from the arm if you have any peripheral arterial disease there, and that can lead to some issues there. But I think that the problem is patients who have peripheral arterial disease have a lot of coronary artery disease as well too, and have a lot of heart problems. And so, especially if you're the type of person that's had recurrent failures, unfortunately, going beyond just cigarettes alone and a lot of other reversible risk factors, there's some genetic factors there too. And so some things in your body that just make you more prone to develop blockage, which makes things a lot more challenging. It's a lot tougher. So I think in a lot of scenarios, like people who have bad PAD can also have bad CAD as well.
For a patient that has PAD, we've had so many patients. We even had Lisa that was just on here a few moments ago, and she was asking about if she has PAD, should her doctor be checking for CAD, and what are the tests that they should request? Because, the doctor is just telling her, hey, you don't have the angina. There's no reason to check your heart. But more than 40% of people who suffer a heart attack show no signs or obvious symptoms.
Yeah. So, this is an interesting question. And there are a lot of docs out there too that will do things like cardiac CTAs and things like that too. But the problem is this, though, we don't know what to do with that information. Like putting stents in that person with no symptoms and no, especially in the absence of actually having a heart attack, it doesn't seem to make people live longer. In fact, there is some risk of harm, but rather what you're supposed to do with some of this information is to be more aggressive with the medications. And that certainly can increase your lifespan and really improve your outcomes. There's always going to be a time and place to do heart procedures, whether it be stents or bypass. But we don't want to do some of that stuff too early because kind of like start the clock. I mean, just like in the peripheral arterial disease, we talk about trying to improve walking to kind of improve collateralization. Well, the same thing is true in the heart as well, too. We want to use good medications and promote collateralization. And there are some people that got severe coronary artery disease, but they don't have any problems because they've got great collaterals and they've been doing very well. And they live a nice, long, and healthy life. But what you should do is if you have CAD, we screen for PAD. If you have PAD, we certainly want to screen for CAD. In terms of screening for CAD, though, doing really aggressive tests, like doing routine stress tests, doing routine cardiac CTAs, at this point has not been shown to be beneficial. We're certainly studying it, and they're very much interested in trying to see whether or not identifying these people earlier will actually change their outcomes. But in my practice, a lot of times what I'll do is I'll do a calcium score. And I use a calcium score not so much to say, hey, do you have underlying coronary artery disease? It tells me you got a lot of inflammation. If you have a lot of inflammation, I'm going to be more aggressive with ways to reduce calcium buildup, like using statins or PCSK9 inhibitors and other medications to really reduce inflammation. I'm going to tell you to do more plant-based nutrition. I'm going to talk about lifestyle things that you can do. Now, certainly if you start developing symptoms, you start getting shortness of breath, you start having a drop-off in exercise tolerance, having other issues, we're going to start investigating more deeply. And you know what it is you want to develop a very close relationship with your doctor so that you communicate honestly what your symptoms are. A lot of people say they don't have any symptoms at all. A lot of times that's not true. It's you're not asking the right questions. And so being able to kind of identify and tease out things that are different than the norm, that's when we get triggered to go ahead. Let's do a test at that point. But we don't want to do routine testing because honestly, it creates a lot of anxiety. It also may lead to unnecessary procedures that can lead to harm. So you got to be careful about that.
The one thing when we talk to our patients, a patient comes to us and they say, hey, we were just diagnosed with PAD. I've actually had symptoms for a long time. I haven't been able to walk very much. I'm, definitely a claudicant. They want me on this rigorous walking program. And we've had several actually have a heart attack when they started the walking program because no one ever checked their heart and they weren't pushing it. They weren't getting themselves to a point where their blood was pumping up like they can actually push. So I'm always saying, hey, you know what? Before you start your regimented walking program, you might want to have an evaluation on your heart because you might not be pushing yourself to a point where it would trigger something. And then you start walking and bam.
Yeah, I mean, and that can certainly happen. A lot of times, some of those heart attacks could have been prevented with good medications as well, too, but people were never put on any of these medicines.
No.
So it turns out they had uncontrolled hypertension or high blood pressure. Heart rate was high. There's a lot of other abnormalities were just missed and not noticed because everyone was focused on the leg blockage, but not on the rest of the body, right? So that's the thing, though. You don't want to miss the forest for the trees, right? So you got to think about the big picture, think of a patient as a whole and not just as a blockage. It's like there's so much more to a person than just an individual body part.
Definitely. Do we have any other questions that are coming in from here? This has been a really good conversation. Go ahead and unmute if you have a question for Dr. Mathews.
I have a question.
Go ahead, Nancy.
Okay. I had a heart attack 9 years ago. I have peripheral artery disease also. My cardiologist stop doing the stress test every year unless I have any symptoms. I am taking Repatha. I am taking Xarelto. I am taking Plavix. I'm walking 15,000 steps a day. I'm eating more plants.
Right.
So I'm doing all these things, but I'm still nervous because I did have this sudden heart attack, and I actually heart stopped, and they had to give me CPR. There was an ER next to me, so I'm very blessed. Is there anything else I should be doing? I mean, should I have a stress? He's saying the stress test, the chemicals they use in the stress test. So this is why stress test.
So it's not so much. So your cardiologist is not wrong. We don't do routine stress tests anymore. There are some folks out there who unfortunately still do regular stress tests. But really it's just to make money, honestly. You know how many patients I've had that have had a stress test and then they have a heart attack a couple weeks later. The stress test completely missed it. Stress tests are a useful tool, okay? But they are not the end all be all. They will miss a lot of patients. Because it doesn't actually show you the actual blockage. It gives you a suggestion of reduction of flow. You can have a patient that's got all 3 arteries blocked up and they have a completely normal stress test. So these are things that are missed. And a lot of patients who can't walk and you end up doing a chemical stress test, even in that scenario, it's even worse in terms of being able to truly identify patients that are at risk. There's also a bunch of false positives as well, too, or we see stuff, turns out it was like an artifact. So there are types of stress tests that are better than others, but at the end of the day, the ability of the stress test to potentially help you identify a blockage is much better when a person actually has some symptoms where they're starting to notice something. So prophylactic stress tests doesn't really seem to help. What you're doing is way more important. You're essentially doing a mini stress test by walking those 15,000 steps. Now, if one day you go out there and you say, hey, I can't do my normal walking regimen, something's causing my energy to poop out, I'm not able to go as far as I'm normally able to, that is way more telling to me than any stress test that we could do.
Yeah.
Okay.
100%.
Yes, they missed 2 blockages I had 2 years in a row with stress tests.
Right, exactly. And those blockages were brewing there, but then you had the heart attack. So that's why, I mean, there are other tests like cardiac CTA, which are better at actually identifying blockages. However, even then, then we sometimes identify blockages that don't actually cause problems or don't have any symptoms associated with it. So it's very complicated. We don't have the perfect secret sauce yet to prophylactically identify patients that are at risk. We're trying to figure it out. And this is something that's being studied right now. And, in the next 5 years, I may have a different answer for you. But in this current day, what you're doing with your walking program and your exercise and all those things, I think matter way more than going out and getting a bunch of tests. Because with all those tests, there's radiation associated with it. So you're exposing yourself to a lot of radiation, unnecessary exposure. And, people who over their lifetime get all this radiation, there is a slight increased risk of cancer. So we don't want to do these things unless we really need to.
Okay. And I do take Repatha and
which is great. Yeah.
Combination drug. They also put me on Zetia.
I
can't pronounce it. It's easy.
Ezetimibe. Yeah.
So they're doing that and looking into something new. So I'm with MUSC in Charleston. My cardiologist.
I know those guys. They're good. They're quite good.
Yeah, they're good. I go and because I have a defibrillator too, so I have a little bit of everything. But I'm glad to hear your answer that we're doing the right thing.
Yeah. And the MUSC folks, I mean, they're academic cardiologists and they're doing the right thing. You'll see that sometimes out in the community, there's a lot of people who believe in doing routine tests all the time. And unfortunately, like I said, it's not going to give you the information that you necessarily want. Sometimes it can, but a lot of times you end up getting a test and it's normal. And can you hang your hat on that normal test? And sometimes we can't.
Okay. And I think, Dr. Mathews, you brought up this one point that's a great point over and over again, which is it's more telling if you as the doctor is asking the right questions, right? You're asking, what are the symptoms? What are you experiencing? Are you slowing down? That kind of thing. That was the difference for my dad was he went to one doctor. He had the 256 slice CT scan and he had 8% growth in his LAD and in his right coronary. And his LAD was over 80% and his right coronary was 97%. And the doctor's like, so how do you feel? My dad's like, oh, I feel great. He's like, okay, then we're not going to do anything. I'll see you in 6 months. He goes to his VA doctor who says, hey, Bill, how's that walking? You know, how are you walking, you know, this week versus, you know, a month ago? And he's like, oh, I kind of slowed down a little bit, but I'm still feeling good. It's like, well, how much have you slowed down? Why have you slowed down?
Right.
Little shortness of breath, you know, things like that. And he's like, you know, you're pretty close to a heart attack here, you know, a major event. And he went in and opened it up.
A lot of people will self-regulate, auto-regulate. They'll start limiting themselves in terms of their activity. A lot of folks, they don't think anything of it. They're like, maybe it happens over time, so they don't really notice it. They're like, oh, I'm kind of too lazy to go exercise now. But sometimes it's because they can't exercise.
Yeah.
And so I think that's really important. Again, asking the right questions and also being honest with yourself too. Are you slowing down? Are you not able to do the things that you're able to do for a reason? And that's our job to figure out, is there something medical that's causing that problem?
Yeah.
Okay.
Any other questions?
Thank you.
Thank you, Nancy. Any other questions for Dr. Mathews before we let him go back in and probably finish? There's a live case going on. It's actually one of our patients that's up there. Is that Dr. Saab? Yep. Dr. Saab's up there. No other questions? Well, I appreciate everyone joining in today. Thank you so much for all of your great questions and your courage to ask them, because your question may be that of someone else. So hopefully you'll tune in tomorrow. We have more doctors coming on, more interventional cardiologists, and a couple of vascular surgeons as well. So make sure you stay tuned, and we will see you tomorrow, everyone.